Regarding implementing end-of-life pathways, there are certain concerns that do arise, and I really want to point these out, in particular because these, even though these points have been addressed, like for example the Liverpool care pathway, there was a lot of work that was done in terms of evaluating it and sort of the kind of responses through questionnaires and the relative responses and family responses to that, and some things really came to the forefront, and hence it, they stopped using it. Now, even though there are some valuable aspects of that pathway, which, to be honest, can be implemented, and they do, bring some level of comfort to dying patients. But some of the points that did arise was in particular on these particular three areas. So there was something about imprecise diagnosis of dying. So the question is, when we as clinicians, for example, when we now think that this person is dying, it to some degree becomes a kind of a diagnosis that you're saying now, look, this patient's going to go quite quickly, so they are dying. And here we will sort of then start moving on, start thinking about anticipatory medication. We start looking at syringe drivers and various other things. Now, the problem that arose was there was no precise way of telling accurately when a patient was in their last few days. And if you look at those trajectories that I mentioned earlier on, you can see why that may be the case. So in that particular perspective, it's important for us to understand and engage with the family so they're fully aware of that. So these are things that are important. So I'm not sort of just highlighting sort of these I'm not nor am I claiming these are Islamic values or anything like that, but these are just general common sense areas that we need to really start thinking about, because they can impose problems even from the Sharia perspective in how we deal with end-of-life care. Because in the Sharia, it's important that we get consent, and for that reason, these things could be very problematic. The other thing is, for example, placing patients on a pathway can lead to considerable distress in relatives. So clearly, if you're going to say to a family that we're going to put them on a particular pathway, they're thinking, what? A pathway? What is that? So then you need to explain. In relatives or carers, when the patient does not die with hours or days or recovers, and especially when you're saying, escalating the matter, because you're saying now you're going to go put them on anticipatory sort of medication and syringe, and then the patient lives on for quite some time. That can be quite sort of a challenge for clinicians as well as families to care for such patients.